Welcome everyone to our annual Palliative Care Conference for the winter of 2023. I hope everyone is having a wonderful year so far. So my name is Elena Robertson and I am a member of the Planning Committee. And our first speaker is Mr. Eugene Dufour, and it is my absolute honor and pleasure to introduce Eugene. Eugene is an individual, marital and family therapist, bereavement specialist, compassion fatigue educator, and a critical incident stress debriefing consultant. He received his bachelor's and master's degree from King's College at the University of Western Ontario. He has been working in bereavement, trauma, work, hospice, palliative care, and the HIV/AIDS movement for the past 30 years. He is a past president of the Ontario Palliative Care Association and the Canadian Hospice Palliative Care Association. In 2002, Eugene was presented with the Commemorative Medal for Her Majesty Queen Elizabeth II Golden Jubilee by the Governor-General of Canada for his work in hospice palliative care. In June of 2019, Eugene was named a Paul Harris Fellow by the Rotary Foundation of Rotary International for his involvement in establishing the Rotary Hospice of Stratford, Perth. In April of 2022, Eugene was presented with the Dr. Dorothy Lee Award for Excellence in Hospice Palliative Care by Hospice Palliative Care Ontario. In March 2012, Eugene and Michelle O'Rourke published their book, Embracing the End of Life, Help for Those Who Accompany the Dying. Eugene is presently consulting the numerous hospice palliative care programs, first responders, and providing trauma counseling. He is working on his second book on complicated grief. He is the proud Pepe to Julia, Aurora, Dylan, Oakland, Everett, Owen, and Isaac. So I present to you Mr. Eugene Dufour.
God. Oh, nailed it.
It looks like my picture is frozen also, so can just want to make sure that everything's.
I can see your your main slide, but if you toggle to the right, can you scroll through it?
Yep.
Oh, there we go. Perfect.
Yep. Okay. So let's go. Well, first of all, thank you for the promotion to being a doctor. The only thing that would relate is my handwriting. And it's really good to be back here in Ontario. I had a lovely visit in Newfoundland, babysitting grandchildren, 5-year-old and a 2-year-old in northern Newfoundland. The 5-year-old knew how to use a skidoo, and so we had to hide the keys every once in a while. She did take Nana out for a ride one day and put her on the back of the GT, and I really wanted to watch that. So as our granddaughter crested the hill and stopped, Nana kept on going, and I heard our granddaughter yell, "Nana, hit the brakes!" And then I heard Nana say, "Where are the brakes?" Took us about 45 minutes to dig Nana out of the snowbank. My other great learning is that if I watch one more episode of Paw Patrol or Peppa Pig, I might do physical damage to the TV. So it's really good to be here. And what a great topic. I'm just thrilled to be able to present on this topic. And it's, to recognize burnout and COVID-related PTSD in ourselves and our colleagues. That's so important because we need to take that step to be able to do that. And then to apply some of the tools and disseminate some of the tools and knowledge. On my first slide is my phone number and email. Please give me a shout in the next couple of weeks if you had any comments or questions, or if some of this triggered stuff. That's really important. I'm supposed to do a lot of painting in the next painting of rooms, and I do anything to get out of that. So feel free to give me a shout. I love this quote. We in the care partnering community frequently encounter people with life-threatening illness at a point when they are no longer who they have been and are not yet reborn into who they will be. We meet them in a place between no longer and not yet. No longer and not yet. That is very difficult for our clients, residents to be experienced, but is equally difficult for us. And there's that unspoken message that because we're healthcare providers, this should be easy, piece of cake, no problems. And it just doesn't work that way around that aspect. If you ever get to listen to any of Parker Palmer's stuff, he's dedicated his whole life to educating teachers. And he says one of the hardest things we must do sometimes is to be present to another person's pain without trying to fix it, to simply stand respectfully at the edge of that person's mystery and misery. Wholeness does not mean perfection. It means embracing brokenness as an integral part of life. And that's one of the root foundations of palliative care, that we don't see dying as brokenness, is that we focus on the living in the dying. So what happens is someone is diagnosed with a life-threatening illness and they enter into that long journey of misery. And as long as they are accompanied by people that have an approach to caring, compassion, and advocacy, that's what makes the misery tolerable. And then that leads to mystery. And I don't mean in the religious sense. I mean, how has their illness, how has this misery affected their vital breath that comes from the depth of them? How has this misery affected meaning and purpose? We're a culture that doesn't talk enough about meaning and purpose. And that's one of the root foundations to burnout. And so one of my big suggestions today is that we need to step out of our professional roles sometimes and talk about meaning and purpose. And I'll be giving you some tools on how to do that in dealing with that aspect. My dad died about 4 years ago, and he was 89, still going to the gym every day. And he just couldn't bench press as much as he used to. So I said, well, Dad, do you think maybe it's because you're 89? He was very incensed. He said, no, I know something was wrong. And sure enough, he was diagnosed with lung cancer and, never smoked a day in his life and was so shocked that he had lung cancer. So I was able to take the compassionate leave program, and I spent 8 months with him doing this. And I now do palliative care much, much differently. I do a lot more listening and a lot less talking, which was so crucial. My mom died when I was 19. So that was like 40 years previously. And I was shocked at how much we as a family and individually had to rework our mom's death. And so I bring that out is that grief just doesn't happen in the present moment. It also takes place in the past and the future. So we continually need to do our own grief work, past, present, and future, in dealing with that particular aspect. You'll notice the picture above my head. My dad was the 13th of 15 kids. My grandfather turned 65 when my dad was born, and he had 2 more children after that. My grandfather was the first person in Ontario to get baby bonus and old age security at the same time. And so it was just a wonder. And there was just 2, my dad and a brother left around that aspect, which was really important. So that's something that's important in dealing with that aspect that we can do. When we went to the cancer clinic, I was with my 3 sisters and the whole team there, about 10 people. And his pain was really well controlled. And so they asked, at the end, my dad said, could I get some medical marijuana? He was shocked. He never said that to us. And the team was shocked. And I said, well, Sam, we really don't do that here. But why? Your pain is really controlled. And he goes, oh, I don't want it for pain control. I want to tour with Willie Nelson. So we had this wonderful, wonderful sense of humor in dealing with that aspect. Trauma-informed care. This is a whole day workshop. I'm just going to do one slide because it's so important that we are just now starting to learn that our practice needs to be trauma-informed care so we don't re-traumatize many of our clients in dealing with that. So it needs to be based around our approach around resiliency and recovery, understanding trauma, based on compassion and dependability. So I never try to cancel appointments because often they're so focused on that it's based around cultural humility and responsiveness. And of course, always based in safety and stability, along with our approaches to empower people. And our First Nations brothers and sisters are teaching us so much about trauma-informed care. You know, I've lived a privileged life. I'm male, I'm white, I had a chance to go to university. I've never known unemployment. I've never known war. I've never known violence. I've never known poverty. And so I need to constantly be aware of that unconscious bias that comes from living with a life, from a life of privilege. I went to King's College in London, which would have been a fairly liberal social work program. And this would have been 75 to 82. And not once was residential schools mentioned. I was horrified to find out that the last residential school closed in 1979 in Ontario, and dealing with that aspect. So we're just learning so much around that. And you folks have the tools of doing that aspect. So here are some of the tools that I'd like to just give an example. And again, Parker Palmer says, the soul speaks its truth only under quiet, inviting, and trustworthy conditions. And you folks as caregivers do that when you go into a patient's room or their hospice room or their home around that. I had a woman that had a horrific history of trauma and needed to work through some of that. She had pancreatic cancer and wanted to die at home. And the nursing staff said, oh, she's willing to see somebody. She doesn't want to see a male. And that's the only person we had on my team was myself. So they convinced her, just one meeting with them. So I read the chart and I saw that the only thing she could eat was bananas. I knew she was on ODSP and that her check hadn't come in yet and that things would probably be pretty tight. So I just brought a bunch of $3.13 worth of bananas. And when she opened the door and saw the bananas, she goes, "How did you know?" And she just burst into tears. $3.13 worth of bananas. So, and then that just entered the relationship around that. Same with the gentleman who was dying of liver cancer, and all he could tolerate was orange juice around that. And I remember my first time, and the nurses said, "You probably won't get in the door." So I brought the orange juice, and that's what got me in the door. He had also, along with liver cancer, he had uncontrolled bipolar depression and was in a manic phase. And when I walked in, he had 3 or 4 guitars set up, an electric piano, a drum set, recording equipment. I said, "Oh, you're a musician?" He said, "No, it's dangerous when I'm in my manic phase. I have a computer and access to Amazon.ca." So I helped him return some of that stuff. I always carry along some meditation beads and these little stained glass dragonflies that symbolize transition. And we talk about that. You can get them online for like $4 or $5. And it's just a different way of approaching our clients in dealing with that aspect. You know, we just weren't ready for this kind of grief. We have all these beautiful rituals and programs that we do. And folks in hospice, I felt so bad for all of us that when our programs are based on contact and having family units there and having to restrict them and not come in, that was really difficult around it. So we were robbed of all of this. And many of you folks were put in a position to be doorkeepers. And that just is damaging to relationships around that. So again, we're starting to heal from that. That picture in the bottom right-hand corner, I was asked to visit some people in a maximum security prison. And I said, "Oh, okay, I'd be glad to do that." They were all life sentence, and many of them had cancer and were dying. I said, "I'll do that, but as long as you let me do a volunteer training program." So we got 20 inmates who were also lifers, and did this training program. And the conversion, the transformation that it took for these people that had done horrific crimes around that was really powerful. So this is what we had to deal with during COVID-19, instead of all those beautiful rituals that we had in dealing with that particular aspect. So I'm going to just chat for about 45 minutes and then just open it up for questions around that aspect of it. So what we found out in COVID-19, all the multiple waves of infection, the increase in the infection rate, every time when we were hitting numbers like 4,000, 5,000 a day, I was feeling overwhelmed. I had to shut off the TV. When we heard that hospitals were reaching capacity, all of us were feeling exhausted, but keeping up the pace, keeping up the pace around that aspect of it. Family members in the hotspots. My son is a firefighter in Calgary, and many of the nursing homes, the residents would pull the fire alarm and they would wait at the door to slip out. Or when they were doing their inspection, they would beg them, "Oh, please take me home with you. I can't take it being here anymore." Plus, then being exposed to it around that aspect. All of us were in the same storm, but very different boat. I never missed a paycheck. I rarely had to leave my home. I overlook the Bayfield River, which is a 2-minute walk away. Lake Huron is 5 minutes away. I had it pretty easy around that aspect. The influence of suffering in our developing countries around that, the fear of deployment, and if you were deployed, and how many people of our colleagues that got long COVID, and just the 3-year thing of the pandemic. So I always remind myself that the root word for bereavement means to be robbed. So we were robbed of our beautiful deathbed rituals, complicated final goodbyes, the restriction in funerals and visitations, those difficult ICU deaths, long-term care deaths, retire home, and then grief overload. I think we're just starting to see the aspects of grief overload for us, for all of us in dealing with that aspect. So I just threw in a lot of slides that I'm just going to refer to because I wanted you to have this information. The statistics are clear. About 93% of us are feeling overwhelmed. 70% are worried about exposing loved ones. Huge numbers of emotional and physically exhausted. So that whole aspect of it. A sense of feeling not getting enough support. And, I need to say, I think our politicians, our medical directors of health throughout the provinces and in the country, I think they did a fabulous job with not having a game plan and no experience around that. So by no means am I being critical. It just, we learned so much around that particular aspect. I never had small kids to have to worry about supporting them learning at home, plus running a career around that aspect. So we need to know about, there's a bunch of things that are happening when we look at burnout. So that burnout is that term that describes the physical, emotional exhaustion because of feeling that overwhelmed. Now, secondary trauma is defined as indirect exposure to trauma through a firsthand account or narrative of a traumatic event. So watching some of our clients, our residents, our family members die of COVID and being separated from them would be considered as secondary trauma. I always thought secondary trauma and vicarious trauma were the same things, and it's just not that way. Vicarious trauma describes that profound shift in your worldview. And that's what makes that so difficult around it. And that's what adds to the feeling of burnout around that. I'm going to refer to compassion fatigue, but then there's that moral distress, moral uncertainty, and moral dilemma. So when you get a call saying 6 people called in sick, can you come in? And you are just exhausted, but you still go in. And that moral distress about, what about me? What about my family? What about my patients and residents, and dealing with that? And then that all leads to incredible amounts of complicated grief. What we need when we do disaster planning, we know that you have that pre-disaster, which gives you a chance to prepare. Most don't have that opportunity. We had very little time. There's then all those heroic measures that we do. Then you kind of reach that honeymoon period. Then there's that period of disillusionment, and then eventually you get to reconstruction. Well, we never got to the honeymoon or even the disillusionment because each wave kept us stuck in the delusionment. And I just plotted wave 3. I think we're at wave 7 and wave 8 right now. And so we haven't really gone through this phase of disaster, except right about now. I think last summer I flew to Calgary to see my son, and it was the first time I had to wear a mask. And I just remember feeling so claustrophobic because it'd been a couple of months since we have to wear a mask around that aspect of it. Now, this is a really important slide. So it talks about our performances and then the level of pressure. So we talk about rust out when things just aren't challenging enough, and then burnout. So we all kind of work in our comfort zone, and that's when we're really effective and we're sort of working on all 8 cylinders and doing really well. Every once in a while, you'll have maybe a demanding, difficult situation that causes a bit of a stress or stretch. And we can all do that for a short period of time. It's when we go into strain and overwhelmed around that. So being in a stretch is a couple of weeks, not 3 years. So many of us are still in that zone of delusion. And when I heard the news last night that in our area there was 7 diagnoses of that new type of COVID-19, I just remember feeling my stomach churning around that, thinking, "Oh no, here we go again, another name around that aspect." So many of us are still working in that stretch, strange, overwhelmed aspect of it. So short-term stress is it happens, and then there's that period of recovery. Well, with long-term stress, you have the event, the event, the event, and then the arousal around that aspect of it. So it lasts much longer, and then it takes longer to recover. So that's why we're so much exposed to burnout in dealing with that aspect. So let me talk to you a bit about experience that I had. So probably in about 6 months into COVID, and there was a nursing home that pretty well all the residents had COVID. The entire nursing staff had COVID. Many of them were calling in from their sick beds and instructing, and like when I say nursing, I mean the whole gamut, PSWs, nurses aides, RPNs, RNs. A director of nursing was also infected. So there was no nurse in the building. And this is before hospitals in the community were deploying around that aspect. So a team was deployed, and I was asked to be a part of that team. So we had 26 deaths in 5 days. And after about a week, this was one of the homes that the military came in around that. I can talk about this, but I can't say the name. I had to sign a letter that I wouldn't disclose the name. So I'm respecting that. But they said I could talk about it for teaching experiences. The most difficult thing was family were not allowed in the building. There was very little supplies were stored in the facility, very little pain medication, and all stuff. So not only were they scrambling to get all that stuff, but they were also dealing with that aspect. Families had to say their goodbyes through technology. I had never used an iPad before. Luckily, the first death that I experienced, this granddaughter was saying goodbye to her grandmother through the iPad. And she said to me, "Could you please press your iPad against my grandmother's lips?" So I did. And then afterwards I said, so what did you do? She said, "Oh, I took a screenshot." I said, "What's a screenshot?" So she sent me a copy of it. And it was a picture of her grandmother, which she interpreted as kissing her. And then she took a screenshot of her kissing her grandmother and framed it. So I said, well, "This is brilliant. Can I use it?" So all 26 deaths had that experience. I would suggest it. So even though we were crippled with not having the people there, you try and did your best around that aspect. So some of the learning, there should have been more than one team. We slept there. We didn't take off our spacesuits. We slept in closets, anywhere that we would not be contaminated. None of us contracted COVID. You'd get a couple of hours sleep. The nurse would wake you up and say, "So and so is not doing well." So then you would get the families on the iPad and stuff like that. So there should have been more than one team where you would then go out of the building, get a good night's sleep, and then come back. So that was something that was key. We can't do this alone. We have to expand it and share the burden of that kind of suffering. Debriefing cannot be optional. We need to embed some type of continuing, ongoing debriefing. Because we were drawn from across the province, it wasn't like it was a team from London or a team from Windsor that came in that knew each other. We were from all over the place. And so when we left, there was no contact. We had gotten each other's names and stuff like that. But then we returned, and once we passed the infectious period, we were back into dancing as fast as we could around that aspect. And there needs to be a continued assessment for complicated grief, complicated or all kinds of difficulties around that, and also burnout and PTSD around that aspect. So it would have been about a year later that I started to have images of their faces, images of those screenshots. So luckily I acted really quick. I contacted my family health team. They were still seeing people in person. I met with a nurse practitioner, and I had stopped. I wasn't able to sleep. I was waking up early, couldn't fall back to sleep. I was just having that sense of exhaustion. And she said, oh, you either have burnout or PTSD. I'm going to give you 3 sleeping pills, and I want you back in 3 days. That was significant, because that's all I needed, was just to break the sleep cycle, and that contact. And then she said, well, I'm going to give you another 3 sleeping pills, but if you don't need them, but I still want to see it in 3 days. And that's what helped break that whole particular aspect of it. She was not trained as a trauma therapist, but it was that presence of her, that listening, and me realizing that I'm not going crazy, that it's not because I'm weak, it's because the situation was so devastating around that. So my suggestion for all of us is to be very, very proactive. Reaching out is not a sign of weakness, it's a sign of strength in dealing with that particular aspect. I was very lucky. I was hired at St. Joseph's Health Center right out of university. I was on the cancer floor. That second week I was on call. I had 4 deaths that week, all after midnights. And it was the same nurse that was on midnights. And what she would do is, after the families left, she would open the window, and I thought it was policy and procedure to air out the room. So after the 3rd, 4th death, I thought, oh, this doesn't make sense. So I asked her what she did. She said, well, for many of these patients, I've gotten very close to them. I've heard their painful stories of goodbye. And this is my little way of letting them go. I open the window, I take a deep breath, I let it out. I'm thankful if they've helped me, if I've helped them in any way. I take another deep breath, I let it go, and I'm appreciative if they've assisted me, and I appreciate all that they've given me. And then I set them free, because I know that darn call bell is going to go in 5 minutes, and I don't want to be robbed of that experience. So that was the other lesson that I learned, is that we need to develop rituals where rituals don't exist. We need to create our own little rituals where we can get it from our hearts to our heads, out there, and reprocess it again, and really dealing with that particular aspect. So this is what I've developed for myself. I call it the 20-20-20 suggestion. So each day, if you can do 20 minutes of brisk walking, if you only can squeeze in 10, it's better than nothing. And the beauty of this is that it's broken into segments. So to find an hour is difficult, but 20 minutes is a little easier. And then 20 minutes of reflection. That means sitting or standing and just thinking. Just let your mind free think, let it what you're thinking. And that's amazing of where you get in tune with where all the stresses is in your body. And then 20 minutes of either inspirational reading or music around that aspect. So try this 20-20-20 suggestion And then send me an email about how it works. I'd like to include that in the second book on complicated grief, in dealing with that aspect. So burnout is bone tired, soul tired, heart tired kind of exhaustion. So it's very, very different from stress in dealing with that aspect. Many times it's diagnosed as depression. Often antidepressants don't work, and that's where we need to become more and more knowledgeable about this thing called burnout and dealing with that. Sam Keen was a wonderful writer. He wrote, "Burnout is nature's way of telling you you've been going through the motions, your soul has departed." So that's where that disconnect. So when I talk about soul or spirituality, this is what I say. It's your vital breath that comes from the depth of you. And I get so much mileage instead of, how are you coping with this spiritually? I'll give my definition of spirituality, your breath that comes from the depth of you. How is your misery affecting that and dealing with that so that we can avoid falling in the pit? So when I look back after being deployed to that nursing home, there were signs of stress. There were physical symptoms. I kind of had a chronic feeling of nausea. There was that sense of being overwhelmed. Compassion fatigue was a little bit more difficult to nail down. I was probably thinking of brownout. So brownout is where, like on the electrical grid, the electrical company reduces the power by 80% so that everybody gets power. But what we don't know is that that's very hard on our appliances and on our electronics. That's a great example of what I was doing. I was kind of robbing energy from one area, and then I was setting myself up for some burnout around that. Then it can lead to PTSD and CPTSD, which we'll talk about in a minute. It's very different from depression. So that depression is often characterized by many of the things that are symptom, but antidepressants doesn't really work on depression around that. So here are just some hints that I want you to have around that self-monitoring and pacing, which is so hard to do when there's so many demands. Regular check-ins with colleagues. So what was really helpful for me during COVID is a group of us social workers met every Monday for an hour throughout the province, and just to do kind of a check-in. My immediate team, we did a journal reading. Someone would pick an article. It couldn't be no more than one page and send it to us. We would have lunch virtually and talk about that. So not only was it the connection, but it was also that little bit of information that was helpful. And everybody had to have their cameras on. We needed that face-to-face contact in dealing with that particular aspect. So Peter Levine, this is what we're finding out about trauma, is that some of the insight type of counseling just don't work. We need to do some kind of body work. So people that are doing yoga and Tai Chi and all those other modes of getting in touch with the body, where we store the trauma, is helpful. He says, "I've come to the conclusion that human beings are born with an innate capacity to triumph over trauma. I believe not only that trauma is curable, but that the healing process can be a catalyst for profound awakening." So that's where it's so important. So I just put that there for that reference. Anything Peter Levine writes is wonderful, and he's got so many YouTube videos out there around that. The basis of dealing with burnout with our colleagues and with ourselves rests in contact, in connection, and also deep listening. So I was trained for probably 30 years to listen, to respond, not to understand. And as soon as I started working really hard at that, it's amazing that the answers come. So listen to understand, not to respond, so that as people are talking, I have an empty mind. I don't have an agenda around that aspect of it. The bottom picture there, as the person is in the midst of their pain and suffering and misery, I'm trying to weave it into this redemptive, beautiful story. When I do that, I'm not listening. So I really try not to reframe, rewrite, or invalidate, but just listen in dealing with that particular aspect. You keep one foot in acknowledgement and one in possibilities. I hear what you're saying. I hear what you're saying. And then planting those little seeds of hope. I was part of a family health team for 10 years, and that was when the ministry would send out evaluations to patients that we saw that we didn't know about. And then we would get the feedback. So my manager came and said, your evaluations are over the top. Your cancellation rate is almost zero. What are you doing differently? I said, well, first of all, I am no different than my other colleagues. We have very skilled therapists, but I changed things about 3 years ago. Before I go out to the waiting room to get somebody, I ask myself this question: what am I here to learn? And that was incredibly different. It put us on the same level. Secondly, I stopped taking notes. Now, note taking is very important. I had to become very disciplined. But at the end of the session, I would say to the client, okay, I need to write a note. Can we do it together? And then in the note, we would plan what we do for our next session. So not only is the client on the same page, so am I, and it's right there. That in itself has been overpowering in making that kind of connection. And the other thing I do when I was in an office is I see people on the hour. Every half hour, I would have a meditation bell that would automatically ring. And people would say, oh, are we out of time? I'd say, no. I hate to admit this, but this just reminds me that the most important person in this room is you, and it calls me to attention because my mind wanders, and I'm really embarrassed to say that around that whole aspect. So again, that whole thing of tailoring where we can be really present is so important in dealing with that aspect. Sitting with a person's pain and suffering with compassion around is so important. So just some information about trauma, what it can break it up to. So I got a couple of slides that I'd like you to spend some time looking at, because when I present that to my colleagues, all of a sudden the light bulb goes off and they say, oh, I'm seeing 2 or 3 that I didn't even think about. So that's where we are a people that need to reflect around that. So that leads us to complicated PTSD. So let's talk just a bit about that, because I think many of us are dealing with this, but we're pushing it down. And it's not because we're weak, it's because we've been 3 years of a pandemic where the demands were so high. So the causal factors are not all that separated. PTSD from CTPSD. However, their symptoms manifest can tell you even more. PTSD is weighed heavily in the post-traumatic symptoms, the nightmares, the flashbacks, the hyperarousal, whereas complex post-traumatic stress includes all those as well as a change in self-concept. That's why this is so much more difficult, is that it actually changes our self-concept, the way we see the world, and dealing with that particular aspect of it. So the other person that I'd like you to refer to is Bessel van der Kolk. Again, just doing some great work. And he says, being traumatized means continuing to organize your life as if the trauma were still going on, unchanged and immutable, as every new encounter or event is contaminated by the past. So learning ways of de-escalating those, of not eliminating them, but how to live with them and dealing with that. And then Peter Levine says, trauma is a fact of life. It does not, however, have to be a life sentence. And that's where we plant those seeds of hope in dealing with that particular aspect. Bessel says, when the alarm bell of the emotional brain keeps signaling that you are in danger, no amount of insight will silence it. So that's why this quote is so important. It's that amygdala hijack. And I do a lot of work with first responders, and they are feeling so horrible about having reactions to some of the things they see. And I say, it's not you. It's the lower part of your brain that's just hijacking the whole situation in dealing with that particular aspect. So these are some things that we can do that can be helpful. And I just throw this slide up to look at on the right-hand side, distress regulation, distress regulation. So the more that we can, first of all, be aware of our emotions and then find the way to regulate them. So whenever somebody, let's say, falls or is in a car accident, the first thing we want to do is stop them from shaking. And that's the worst thing we can do. The body needs what we call shake, rattle, and roll. So when I'm feeling overwhelmed, when I got about a year out of that experience with that long-term care facility, my body needed to shake, rattle, and roll. And I was stopping it from doing that for about a year in dealing with that aspect. So again, just some suggestions around if you feel you have that sense of complex post-traumatic stress. You know, the whole thing about disorder, there's now a category in the DSM-5 on grief. And a lot of people are upset with that because it then kind of medicalizes grief and it's a normal response to a loss. So I get that, but on the other hand, it now gets us where insurance companies are going to pay for grief. And that is so important in dealing with that particular aspect of it. So again, just some ideas of after that period of caring for those with COVID-19, seeking out and sharing that social support, checking in with other colleagues. So again, that was so important around that, where often we just kept on getting busier and busier and busier. You know, that use of alcohol or illicit drugs, it can be as simple as taking Gravol to sleep. It's probably, you know, it's safe, pregnant women take it. Under stress is probably one of the worst things to do because it leaves your brain in a bit of a fog. And that's what makes that really difficult. I came across this when I went for a walk in Newfoundland with the grandchildren. Taking a break from work. We were just outside of Deer Lake in the Humber River, and I came across the wind phone. This started in Japan after the tsunami, and that's the top one. They've actually have a phone booth where you can go in. They have a phone, and it's not connected to anything. You just have a conversation with your loved one. So the bottom one is the one in Deer Lake, and the one in the far right is the wind phone in BC. What a wonderful way of dealing with that. And I throw that to mention we need to find creative ways of getting that inner dialogue out of our head and hearts, out of our vital breath, out there and dealing with that aspect. So the one in Deer Lake, this is what it says. Though I've lost you, I can hear your voice. In the silent echoes of your absence, you speak to me through rustling leaves, whistling wind, and bowing branches. So it cost $80 to set this up, and it was their family health team in Deer Lake, their wellness program that did this around that. We have so many beautiful nature paths. What a great idea. There's one city, a very large city, they have it in their train station. So it doesn't have to be a place of solace, but maybe even a busier place. Again, little signs of hope around dealing with that. Pema Chodron's that Buddhist priest that says, the truth you believe and cling to makes you unavailable to hear anything new. I am shocked at how many blinders I have. And that's where continually being connected with what my vital breath, my head, my heart is saying, along with that chatter that's going on in dealing with that particular aspect. This was my first experience. I said I would never abandon my clients if they asked me to be present for MAID. This was my first experience. And this was about 3 years before COVID. He went to teach English in Japan, met a woman, got married, and she's over in the corner there on iPad. She couldn't get out of China. And so she partaked in that around that aspect of it. And again, all the unconscious biases that I had around MAID and just saying, it can be in my value set that, I advocate for palliative care. MAID is not in the toolkit, but people have that choice, and I'm just not going to abandon them around dealing with that aspect. You know, despite the PPE, we still begin connected. So home improvement, Tim the two-man tailor, and his good neighbor, Wilson, you never see his mouth. but he can communicate through his hands and his eyes. You know, that's one of the things that I learned from COVID, is to step up the physical contact in dealing with that aspect. The sponge analogy. So if a sponge has that ability to absorb and to squeeze out, but if it sits in the water too long, it loses its ability to do both. We need to step back, get out of the water so that we continue to absorb and squeeze out the stories of suffering, so that we can really be there for our clients and our patients and residents. So just the difference between stress and burnout. Stress characterized by overengagement, result loss of energy, and it takes a physical toll. But burnout, it's characterized by disengagement, results in that loss of motivation, and it takes that emotional toll of then being disconnected from self, and that it really affects your self-concept. Again, I want you to reflect on this because there's so much about it. But just the cycle is, when we have the crisis of COVID, we worked harder. There was the chronic stress, we worked even harder. There was the denial that we were feeling the stress of it, we continued on. We were starting to see signs of it, even signs of burnout. You then have that honeymoon phase, and then you go back into working harder, and it doesn't get to that root. That's why the 2020 allows us to stay grounded in, what do I need? How is it affecting me? How is it affecting my vital breath in dealing with that aspect? Again, just a different aspect of looking at burnout and the brain that I wanted you to reflect on. So here's the definition of compassion fatigue that we know, but it's the stuff that I highlighted in the back that is really important. The most insidious aspect of compassion fatigue is that it attacks the very core of what brought us into this work, our empathy and our compassion for others. So that's why compassion fatigue and burnout takes that step deeper into dealing with that particular aspect. Another slide just to look at how the hallmarks of burnout, compassion fatigue, and vicarious trauma that I just want you to have. As you can see, I packed a lot of stuff in here so that you can have time to reflect on this and have that aspect. What happens with, there's these complex relationships between work, our relationship to clients, our personal lives. So the compassion fatigue satisfaction test, if you just Google that, it comes up 60 questions that evaluates your compassion fatigue, your burnout rate, but also your compassion satisfaction. So I was very lucky to always have an EAP. So once a year, I book an appointment. Once for 17 years, it was the same person. I would do the compassion fatigue test. And I was shocked. When I thought I was doing really well, the test showed me I wasn't. So again, it just gave me a chance to be reflective in dealing with this particular aspect. There's this 2 types of stress. There's routine stress, traumatic stress. So we all have this psychological coping container. But traumatic stress goes to the bottom. It's too hard to handle, so it stays there around that. We compartmentalize it for long-term storage. It does not heal, and it remains painful. That's what I did for the year of keeping busy around that. With enough time, the routine stress can evaporate, work its way out, but too much and too soon leads to spillover. So often the routine stress will then connect with the traumatic stress, and it'll be complete burnout in dealing with that. So we need to find ways of speeding up the offloading. And to heal the trauma, we need to clean out the container. And so talking to colleagues, doing the 2020, being aware of dealing with that. And again, there's no sign of weakness in getting the help that we need in dealing with that. So that our stress buckets need lots and lots of faucets so that we can deal with that in many different ways around that aspect. I'm so lucky to have a lake right next to me with a long beach. And there's something about the walk and the crashing of the waves just is really healing. I love this slide because sometimes I'll get home and my family members will be visiting, and all of a sudden they'll say, "Dad, it doesn't feel like we're alone." And so I started this little ritual. I have this big maple tree outside my door. As I walk by it, I give it a whack, and I put everybody in that I'm working with on the tree with the promise, I'll pick you up in the morning. But right now I need to be present to myself. I need to be present to my family and dealing with that particular aspect of it. This is my granddaughter, Julia, when she was about 3. So I said, oh, Julia, what are you doing? She goes, oh, Pepe, I'm practicing to be just like you. I'm working on it. I've lost 20. I probably need another 30 to go. I'm working on it, the little rascal. I do this with all my clients, and I'm going to recommend that you do it. It's called a hug blanket. So I did this one for Julia. And I show you with a great deal of embarrassment to show that you don't need to be an artist to do it. Not sure why the arms are so big. Not sure why I put elbows on both sides of my arms. The muscles are definitely not that big. The waistline is not that trim. I've written a book, a bunch of articles. I still don't know how to spell, but I think I nailed the glasses. And then what you do is whenever you need a hug from your loved one, you just wrap yourself around the towel with the blanket. You can get them at Giant Tiger. Often they're made in Canada. When they go on sale, they're like $4. And all you need is a permanent marker. Any color will work around that. I was working with a young mom with 4 kids, was dying from breast cancer, and we got one done and she died. And we all felt horrible. And then the 3 home care nurses said, I think we should be the ones that finish it. So they made it kind of identical to what the first one was, and they presented it to the kids on Mother's Day in dealing with that aspect. So again, we need to step in about spirituality. Spirit means breath, soul means from the depth of you. How is this affecting their vital breath? And this is a wonderful door into that because there's so many different varying experiences about religion, but most people are very, very spiritual. And how to get into that is so important in dealing with that. That can be helpful. I have lost track of time, so please tell me how much time I have left, and because I want to leave a good chunk of time for questions. So when we talk about meaningfulness, meaninglessness, you look for significance. Isolation, step up our thing with relationships. Being powerless, how can we empower in dealing with that? And again, presence is so important in dealing with that particular aspect around it. So that vital breath is to devote present attention, respectful assistance to helping people to discern what is this meaning in life now in this new environment of pain, and how they seek to live out that meaning as life unfolds. So the heart of vital breath work, intention. What is my intention when I go into this room? What kind of attention do I need to give? The most important thing is that power of presence, respectful assistance, walking with them when they're discerning, focusing on meaning and purpose. So that compassionate care, sympathy means you hurt. Empathy means I feel that you're hurt, but compassion is I'm called to take action. And that's where you share your vital breath. That's so important in dealing with that aspect. Okay, I'm just getting a message here to annotate. Frank Ostastecki has these 5 invitations when someone's discovering that someone is dying. Welcome everything, push away nothing. So I use this for myself when I'm dealing with a difficult situation. So I welcome everything. I try and push away nothing. I bring my whole self to the experience. Sometimes I like to just stay in my head. I'm guessing that's a male thing. So I'm constantly pushing myself out of my head. That's why the walk is so important, because I can then feel where some of that is residing in it. Don't wait. When it comes to emotional work, I'm probably the greatest procrastinator. So do it now. Find a place to rest in the middle of things. It doesn't have to be done at all once. And the thing that I love the most, that I'm probably best at, is find a place or cultivate a don't know mind. So I don't know. What do you think? That is so important in dealing with that particular aspect. Relationship completion. What to say to a dying person, or what do we say to ourselves? So this is the work of Ira Byock. And he says, a dying person may need to say, please forgive me, I forgive you, I love you, thank you, and goodbye. Well, I do that usually every Friday night. I review the people that I've walked with, that I've shared vital breath with, and I review these 5 things. And then I do that closure of goodbye. This is the garden I have in the backyard. I have over 200 hostas. And I have a little memory garden that I write the name of the client or loved one that had died. I have a little pot that I burn, and then it becomes part of this garden. So physically, I've gotten it out of my heart, my head, my vital breath, and I've put it in a respectful place. And it allows me some kind of closure in dealing with that particular aspect. Alan Wolfont, his companioning things are so important around that. Being present to another person's pain, it's not about taking it away. I love this one. Going into the wilderness of the soul, their vital breath with another human being, it's not about thinking that you're responsible to find the way out. So look at his 11 tenets of companioning around that aspect. That is so important. And I've did it in a page that has all 11 just there and dealing with that aspect. Remember, we confront a lot of human suffering. And the more that we can do this, it's about connectedness. It's about that whole aspect of just being there. It's that nurse practitioner, giving me a practical thing like 3 sleeping pills. And then I need to see you again around that. Instead, here's a month, come back in a month. I felt so cared for in dealing with that. This is probably one of the most important slides that we need to spend some time with in the next couple of weeks. It's that window of tolerance. So we all need to kind of our comfort zone, that ability to self-soothe, to be calm, cool, collected. But when we hit the hyper-aroused, you go into fight or flight, or the hypo-aroused, freeze, fade is another good word. And it's the getting back to your window of tolerance that keeps us really grounded, that can be helpful. And this is how you do it. So I did some advanced training in Oklahoma on the 10th anniversary of the Oklahoma bombing. So they had the instructors from the SEAL teams and the Canadian Special Service Forces. And this is what they developed this square breathing or regulated breathing. And if you notice, they do things in 4. They do 4 steps, they stop, they do another 4 steps. It's to regulate their breathing to keep in their window of tolerance. So this is a really helpful tool. I'm amazed that if I'm driving in a snow squall, before I know it, I'm doing square breathing. And it just takes the stress away around that particular aspect that can be helpful. Again, just looking at the 4 different quadrants of self-care before, during, ongoing, and then right after are really important in dealing with that aspect. If you want to grow as caregivers, you must do something alien to academic culture. I would even say to the medical culture. We must talk to each other about our inner lives. Risky stuff in a profession that fears the personal and seeks safety in the technical, the distance, and the abstract. Let me give you an example. About a year ago, I was working with a mom who had a 4-year-old daughter, and the mom was dying. A very spiritual family. They really shared their vital breath. Heaven was a big part of their discussion. And the mom had this 4-year-old girl. She asked me, what's heaven like? And I just kind of panicked. How do you describe heaven? This mom had a beautiful way of presence. So that's what I went to. And I said, well, I talked to the little girl about the wind. Some days it's strong, warm, cold, or gentle, but that you can often feel it, even though you can't see it. Your mom's presence is like that. Even though she may not be here physically, you'll be able to feel it. I then went on to explain that the days you do not feel that presence, you ask other people about your mom, and they will share their experience and feelings of your mom's presence. And that's what's going to help you. I said to the little girl, this was my experience of heaven. So it was a huge risk to step out of the clinical and share this. About 2 months ago, on the year anniversary, they came back to the hospice. So I saw her and she said, I visit my mom every day in heaven and I don't even have to leave my bed. you never know when you take that risk, the huge impact that can have in dealing with that particular experience. So let's get back to presence, because this is how we're going to deal with burnout. This is how we're going to deal with compassion fatigue. And let's go to the father of palliative care in Canada, Balfour Mount. He says, when pain and other symptoms are controlled, there really is limitless potential for quality of life at the end of life. A key component is that it's not about ending things. It's about the present moment. That's all that any of us have. It's just now. And it turns out that there's endless potential in the present moment. Which is more important, asked the pupil, the journey or the destination? It's the company, said the teacher. When we deny the story, it defines us. When we own the story, we can write a brave new beginning. And after COVID, and as we're still in the midst of it, by this focusing on this brave new ending, we also can get in touch with how we move forward. So again, thank you for this wonderful opportunity to speak to you. We'll open it up for questions. I think there's going to be a discussion group in the weeks to come of answering the questions. But also, if some of this stuff has triggered you, please send me an email or a phone call. I'd be love to chat with you. Let's open it up to questions.
Thank you, Eugene. That was a wonderful presentation, as always. Just a reminder, I didn't mention it before our speakers started. We are going to try to address as many questions as we possibly can throughout the presentations today, but due to the large number of participants that we have, we may not be able to get to all the questions, but our questions will be extracted and emailed to our presenters, and they will reply to those comments, and all the results, all the answers will be posted on our website under the resource tab later next week. So we do have a couple questions for you, Eugene. One of them is, do staff also need that quiet spot to be able to share their truth about their feelings in terms of caring for palliative patients, especially during COVID? And how can we build that into their workday if we do?
Yeah, that's really important. I do a workshop, I'll do it at the Provincial Conference again, on how to create a debriefing program or even a culture towards debriefing in our programs and in our hospices, because it needs to be done regularly. It needs to be paid for. It needs to have that aspect of it that's so important. So yes, and so finding daily ways. I would love for a group to do the 20-20-20 as a group. No one has done that, but I would. If some of you would like to do that as a group and get back to me, that would be really helpful around that. So any practical way that we can get it from here to here, out here, and reprocess it is really important in dealing with that aspect.
Definitely. I know I worked at long-term care homes here. I was assistant director, and I know the staff really had a hard time when the residents passed away, because they did care for them for a long time. And we know in long-term care, once the resident passes away, those beds are filled very quickly. So it doesn't really give the staff a long time to process everything. So I found pulling the staff aside and talking to them and letting them, debrief and having them express their feelings and their concerns was really helpful. So I think it's something that definitely should be brought into the workplace.
Yeah, we've worked with some nursing long-term care facilities where staff can do this. There's kind of a blessing of the room after somebody has died, and it acknowledges who just left and who's just coming in. And staff find that little 5-minute little reflection. Nobody has to come in to do it. We empower the nursing staff to do it themselves. That are important. I was asked to help out with some debriefing in Nova Scotia when they had those 22 murders. And so there was, I think, 200 first responders. It was on Zoom, or a type of Zoom. And I thought, oh, I've never done a debriefing like on Zoom, and I don't know if this is going to work. But their webcast had the ability for them to ask questions anonymously. So for first responders, that was so helpful to get to what people were really thinking and feeling around that particular aspect of it. So there could be a role of doing it virtually that can be helpful.
Next question. Are there resources available to help someone with burnout, and how long would it take for someone to recover?
Yeah, it's so individual. Finding somebody, and then again, I'll put a list of resources of what's helpful. So it's good to do some, own reading about somatic therapy of dealing with the physical aspect of it. So finding somebody where you can do that, and then just doing some of that, like doing your thinking while you're walking, of getting addressing some of that aspect of it. So we got to get more comfortable and more knowledge about that somatic therapy that can be really helpful around it. Because often it gets confused with depression. And so the use, now a good depression assessment is important, but if it can be masked around that can be really difficult. Most of our wellness programs kick in after we're off. So if we can have our wellness programs kick in right at the time of a stressful situation, that's what's going to be really helpful. It needs to be more preventative in that aspect of it.
What about the times despite the rituals, the writing of the names and the burning, you can't release the person or the experience?
What a great question. And that tells me that I don't have to. It means they've had such an impact on my life that it's there to teach me something. And that's okay too. So I always say to myself, okay, I can't let go of this. It's not done the teaching yet. So what am I to learn about that relationship, about myself, around that? Why is this one hanging on a bit longer around that aspect of it? I had a client who died by suicide, and she had beautiful green eyes. Oh, once a year, I'll catch myself when I heard about it. I kept on doing this. I was shaking my head. I just don't understand that. So about once a year, I'll catch myself just kind of shaking my head, and I need to do another little piece because I often then see green eyes. She had the most beautiful green eyes. And so what else is that to teach me? So that's what I say. And then give ourselves permission that it doesn't mean I'm not doing it right. I'm not an effective caregiver. It's the little tap on the shoulder. You need to think about me some more.
Wonderful. Let's see here. Oops. So there seems to be no resource allocated to spiritual care. There seems to be a piece missing in palliative care in the community program. Any suggestions?
Yeah, really advocate for it, and look at different models. So where we have in the Southwest, it's called the role was psychosocial spiritual care and bereavement consultants. So the LIN is I would say maybe 10 of the LINs. Oh, I guess there don't 10 offices have spiritual care providers, and we need many more. So I'm working with that group to really dictate and explain what their role is, how it benefits, so that we can continue to press that on. You're right, that's a huge piece. And part of that is to help support and train staff so that you are encouraged to share your vital breath, and when is it appropriate around that aspect, around that can be helpful.
Okay. And what would you say to our MDs, nurses, PSWs, and frontline staff who were in the field during the first year of COVID and now express that they cannot simply return to work and face that again?
There's so much of the profession on those three areas are leaving, and so that they might need a break from it. Yeah, I wish we could build in a sabbatical year like university professors do. I think every profession should have that. I would say to them, take a 3-month leave, even if you have to go on sick leave for a while, before you leave the profession, to kind of get in touch with what is it that was so devastating about it. At the beginning, the hero status that we were put on, and then about halfway through, they were picketing hospitals, and just the change in it was unbelievable. And that's just because of the stress of the pandemic, and the whole difficulty about immunization that really clouded our response in dealing with that aspect. I would say this is a time to be ever so caring, loving, and gentle to yourselves, and maybe taking a couple of months off before you do anything. I think that's important. And that's where getting it documented with your family doc, so that you can, because not too many people can just take 3 months off without pay. This way you get the benefit of a sick leave. We need to broaden our horizons around taking time off, so that we can be rejuvenized around that aspect.
Absolutely. We have a question here. We have a participant who works in the community with people who have dementia, and here caregivers state they have already lost the person. We try to bring an understanding of dementia to caregivers, that their loved one is changing and trying to learn to love the person for who they are becoming, knowing the difficulty with this. Your first quote from Join Brozenko really touched me. Are there any suggestions you can offer when speaking with families about the loss they are feeling when their loved one is still with us?
And that whole thing with dementia, what I often say is, you're right, they've changed. They might not remember you, but you remember. You remember the history, and you honor that history and celebrate that history and stay connected to it. And that's what's important. They may, because of the illness, be forgetting about it, but mom and dad, I will remember. And that's part of the thing that keeps it in the present moment, that can be really helpful in dealing with that particular aspect. And you're right, there's so much more that we need to learn about dementia and how to be present with people when there's been so much change in dealing with that aspect of it.
Absolutely. Are you aware of any facility where dedicated staff time has been made available for ongoing wellness initiatives during the workday?
Yep. I have a list of things, so I'll put a list together of what some groups are doing that are fairly creative, so that they can take time off. And this is where, when we talk about staff retention, I get paid when I go to debriefing. If someone's off shift, they don't get paid. That's not right. If we think it's really important, if they came in to do any other type of training, they get paid for. We need to show the value of that. And I think that's where staff retention will improve, if we'll say, okay, we incorporate 20 minutes a day of wellness. And this is sort of the things that we like to encourage around that. I worked at one hospital where after every code, we took 10 or 15 minutes to say, okay, did the crash cart, did it work? Were all the medications there? So then you feel comfortable that you're dealing with the physical, and then you get to, okay, so how are you feeling? And then all of a sudden I'll say is, well, that person so reminded me of my grandfather, and I would be devastated. So then you get in touch with some of that emotion that can be really helpful. That picture that I showed about the car in the cornfield, what had happened is, because this is a great example, somebody missed a stop sign and plowed into this car. It was a 50-year-old woman and a 26-year-old woman. So they got there, they extricated the 26-year-old, and there was vital signs absent. So the firefighter, a young firefighter, unbuttoned her blouse and saw breast pads. She was a nursing mom. He looked into the car and saw a car seat. So he told his colleagues there might be a baby in the car or somewhere else. The 50-year-old, who was the mother of the 26-year-old, said, yes, she has a 6-month-old at home with dad. So was not in the car. So they resuscitated, got the Air Orange, take her to University Hospital, and she died about 6 hours later. So when I did the debrief, there was 20 firefighters there and this guy's wife. And she said, I'm not leaving until you tell him what you're doing. So what he was doing is he was driving out to the cornfield, so-called looking for the baby. wasn't really looking for the baby. He was trying to find meaning and purpose in all of this because he had a 4-month-old at home. He would have never known what a breast pad was until his own personal experience. And how am I going to protect my little girl? How am I going to make sense of this? So the fire chief said, okay, get in the car. I'm going to take you to the hospital. No, just wait a minute. I said, is there anybody else here that's on the same shift as him? Can you meet at Tim Hortons and then go to the cornfield? So they did that, 3 or 4 times at 4 in the morning. And then they would do it at midnight. They'd have a coffee and then go to the cornfield. And then they were just staying at Tim Hortons. It was connection that he needed to work this through with some of his other firefighters. So we can't pathologize this around that. So as a result, twice a year, I do a session for all first responders in this area, and I invite their partners. And I tell their partners, okay, when your loved one comes back from a call, you ask them 3 questions. Do you need to eat? Do you need to sleep? Or do you need to talk? You get to choose which order, but we're doing all 3. That's a really good thing for us. Do we need to eat? Do we need to sleep? Do we need to physically take care of ourselves? And then we need to talk, and all 3 are going to be mandatory. So we need to find somebody that's going to be there with those 3 questions with a connection point of view.
As a PSW UCP, I was blamed for the passing of a resident back in 2020. I never dealt with this, and I do have PTSD, CPTSD from finding my resident. The question is, does it take longer to heal when you have pushed the grief down for years?
You know, there's no right way or wrong way, there's your way. And by saying, oh, I pushed it down too long, when a student's ready, a teacher will appear. So I would just say, give yourself permission that it needed to percolate for a while for whatever reason. And this might be the right time to do it. So the more that we can, take the guilt off of us, there's so many choices that we make that do harm unintentionally around that we need to give ourselves a break, and that, okay, this is the right time. My focus this year is to deal with that. You're right. The more that I always have a saying, what the mind suppresses, the body will express. So we can only suppress it so long till it's like a jack in the box. Eventually it's going to pop up and say it's time for us to deal. But give yourself permission that pushing it down was probably a survival technique to get through all of this. And you might be in a better place now to deal with it with some distance around that.
Great advice. Do you know of some hospices that have a program set up for supporting the staff? Looking to set something up, but starting from scratch is intimidating.
You're right. Yes, there is. Again, I'll put that resource together and then we'll put it on your website. These are really good suggestions, because why reinvent the wheel in dealing with that particular aspect?
And I think we have one more question here. I believe that somatic therapy accompanying other therapies is not the key related to releasing trauma, but identifies to a more individualized personal attention.
Good comment. You're right. And it's all what works for you. Some people talk therapy, and somatic is a lot of talk therapy, but it's finding out what the triggers are, and instead of just pushing down the triggers, working with the triggers, that they're there for a reason, and dealing with that, and that the body needs to shake, rattle, and roll. And how do I do that with my own unique sense of personality and techniques around that? So that's a really good evaluation. Again, it'd be a whole day workshop on somatic therapy that can be really helpful in dealing with that. Again, never underestimate the power of your presence. I don't know what to say, I don't know what to do, but I'm going to be there. That can be very helpful in dealing with that aspect. Someone just mentioned brain fog. That's one of the classic things about depression, burnout, is that brain fog, and finding ways. And we know that all programs that deal with that, they start off with a brisk walk for 30 minutes. So that physical, and you don't need to do a marathon. It's that whole aspect that's important in dealing with it.
Do you have any words of advice for someone living alone, returning to an empty house after every shift?
Wow. Finding a way to kind of acknowledge your strengths and what are you finding difficult about going to that empty home. And when I go to the empty home, is there ways of self-nurturing myself, of some really good self-care, but also maybe a plan of, okay, do I need to reach out to somebody? Um, um, Hospice Ontario, for the first 2 years of COVID, had an on-call line of people that, and there was about 20 of us that manned it. And boy, it was exactly that. People coming home alone and just needing to chat about their day and some of the difficulties. So developing a self-care plan, being very concrete, being practical, and doing things that are going to work around that particular aspect of it.
Oh, we just had one more question pop up. How do you get your organization to understand, oops, yeah, it just left. How do you get your organization to understand these safeguards of sharing need to be a part of the job?
Yeah. Best by doing it by a team. Get a team together, a committee, a working group to say, how's the best way to approach this with our group and dealing with that. That can be really helpful in dealing with that aspect of it. So not doing it alone, coming up with a group, maybe call it a working group. I find those to be most helpful so that there are different approaches to different management that can be really helpful. And I'll end with one final story. When I was at Canuck Place Children's Hospice, I had to go to a lot of golf tournaments to receive these ridiculous checks. So one in particular, this guy came up to me. I recognized him right away. Very famous Canadian Football League player. He played his whole time with the BC Lions. He said, I just retired, and if there's anything I can do for the hospice, let me know. I said, great. I got his card. About 4 weeks later, we had a 14-year-old boy come in. He had to take 2 planes and a boat ride to get to Canuck Place. Stomach cancer, so he was going to do end-of-life care there, and his parents were going to stay, and a lot of pain issues was also why he came. So I went in to meet him, and he had the BC Lion flags, posters all over, jerseys hanging. Huge fan of the BC Lions, but he had never met a player or been to a game because he lived so remotely. So I leave. I call the guy, football player, say, hey, I got this 14-year-old boy, loves you guys. Can you come? There's this long pause, and he said, I was thinking of running a golf tournament. I don't think I can. I don't think I can visit a boy that's dying. I said, look, just come and talk about football. I promise. If there's any difficulty, I'll get you out. So I did tell them. I meet the guy in the parking lot. He comes, gets out of the car empty-handed. No autographed football, no autographed jersey, empty-handed. So I thought. I bring him in. Little boy recognizes him right away. He's bouncing off the table, off his bed. He's so excited. So they start talking about football. He had won 2 Grey Cups with the BC Lions. And all of a sudden, the little boy puts down his head. He said, you know, the hardest thing about dying, he never said that word before, is that I'll never be able to play football. So I'm about to yank the football player out of there. And what does the football player do? He slips off his Grey Cup ring, gives it to the boy. He says, I want you to hold this ring. When the pain gets really tough, you just hold it and squeeze it. And when you get scared, just squeeze it even harder. And when you're done with it, get it back to me, give it to your mom and dad, and they'll get it back to me. We all have Grey Cup rings. Some of them are bright and shiny on full display, and some of them are in the bottom of pockets, purses, and dresser drawers. We all have Grey Cup rings. And you are more than willing to slip off your Grey Cup ring every day, every shift, every client, resident that you see. But there's a cost to slipping off those Grey Cup rings. And as long as we provide excellent and compassionate care to ourselves, we'll be able to continue to slip off our Grey Cup rings.
Wonderful. Thank you so much, Eugene, for the wonderful presentation. Very insightful and powerful as always. This concludes our presentation from Eugene. Our next presenter will be at 10:30, so you'll have a little bit of a break here. Just a reminder to the participants to complete the evaluation for the session, and the link will be in the chat and on the website as well.